Solitary plasmacytoma, SP, is a rare plasma cell tumour. There are two subsets of SP, solitary plasmacytoma of bone, SBP, and solitary extramedullary plasmacytoma, EMP, which originates in soft tissue. The diagnosis of solitary plasmacytoma is more prevalent in older males. The 10-year overall survival rate of patients with SP ranges from 50 to 70%, which is dependent on type, stage of disease, and probability of progression. However, SP has a high probability of progressing into multiple myeloma, MM. Within 10 years of diagnosis, 50% of SBP patients develop multiple myeloma. Unfortunately, due to the aggressiveness of the cancer, multiple myeloma has a 48% 5-year survival rate. Each type of plasmacytoma has a specific treatment plan. For an SBP, localized radiation therapy alone is recommended. In comparison, an EMP is resected surgically, followed by localized radiation therapy. For cases where more than one lesion is detected or a diagnosis of multiple myeloma, a more invasive and aggressive approach is taken, using systemic chemotherapy accompanied by resection and radiation therapy where necessary. Due to the different treatment options, it is critical that the initial diagnosis and staging is correct. The purpose of this presentation is to evaluate the effectiveness of current imaging modalities for the diagnosis and staging of solitary plasmacytomas. To do this, I conducted an extensive literature search of the PubMed, SpringerLink, and University of South Australia library databases, using keywords to refine my search. Articles were included that were peer-reviewed, published within the last 10 years in the English language, and full text was available. In total, 8 articles were reviewed. Current literature states that both MRI and PET-CT are widely used clinically for the diagnosis of SP. To summarise the advantages and disadvantages of both modalities, I've created a table using extracted literature findings. It was found that the sensitivity and specificity of lesion detection is similar in spine and pelvis imaging. However, PET-CT imaging has been found to be superior for soft tissue and extremities. A major advantage of PET-CT imaging is the ability to scan the whole body to identify additional asymptomatic lesions in a single examination. In addition, several studies have reported that SP appears to be 18F-FDG avid, although research into the metabolic behaviour of SP is limited. The ability to identify hypermetabolic lesions is beneficial for treatment planning and follow-up imaging to determine if the lesion is still active. In comparison, MRI is superior in excluding false positives and has better diffuse tumour definition. For EMP imaging using PET-CT, plasmacytomas are often hypermetabolic, presenting as lesions of focal FDG uptake on the scans. On an MRI, EMP appears iso-intense on a T1-weighted MRI, iso to hyper-intense on a T2-weighted, and has variable enhancement post-gadolinium contrast. In comparison, the SBP has low signal intensity on T1-weighted MRI, high signal intensity on T2-weighted, and homogeneous enhancement post-contrast. SBP enhancement on PET-CT is similar to the appearance of EMP, appearing FDG avid if the lesion is hypermetabolic. The standardized uptake value, SUV, is a semi-quantitative measurement that considers variables such as injected FDG dose and patient size to calculate the tracer uptake in an area of interest. With reference to the image above, the FDG avid lesion has an SUV max of 6.2, which corresponds to moderately high metabolic activity and as a result is an indication of an active tumour. Throughout my literature review, I found that many articles reviewed the significance of SUV in PET-CT imaging, particularly post-radiation therapy. Results show that the specificity of PET-CT for identifying possible residual disease post-treatment is low when SUV was less than 4, resulting in false positives due to post-radiation therapy inflammation. However, when the SUV is greater than 4, PET-CT accurately identifies the presence of disease, improving the specificity. A cutoff SUV max of greater than 4 should be used for the staging and restaging to increase specificity and limit false positives, which may result in unnecessary further treatment. By using PET-CT imaging during diagnosis and follow-up, imaging throughout treatment can remain consistent. In summary, both MRI and PET-CT have their advantages and disadvantages. However, the significant advantage that PET-CT has over MRI is the accessibility and availability for whole-body imaging. While a pelvis and spinal MRI results in similar sensitivity, the detection of additional lesions outside of the field of view is not possible. This is vital for identifying any additional pathology and spread for staging and diagnostic purposes. As mentioned earlier, the type of SP and signs of progression are vital information when creating a treatment plan, due to the diversity in treatment and the deadly consequences of possible progression. An example of the importance of accurate diagnosis for appropriate treatment was reported by Zhang and colleagues. In this case study, the patient presented with 3 months of nasal obstruction, which through a nasal endoscope was diagnosed as plasmacytoma in the left nasal cavity with suspicion of primary EMP of the nasal cavity. An 18F-FDG PET-CT, as seen on the screen, was performed for further evaluation. Image D, the fused PET-CT slice, shows FDG uptake at the site of the suspected EMP, indicating an active tumour. However, a second metabolically active lesion was located in the left pubis, as seen on images A, E, F, and G. The biopsy results of the lesion indicated the presence of neoplastic plasma cells in the bone. Due to the identification of a new bony lesion, the treatment plan was altered for a more invasive therapy. Initially, the treatment plan was only resection and radiation therapy of the nasal EMP, but instead, due to the identification of multiple plasmacytomas, the patient underwent a resection of the nasal EMP, localized radiation therapy for the nasal cavity, and left pubis lesion, as well as chemotherapy. This field is continually changing, and new imaging modalities and techniques are constantly improved to more accurately diagnose SP before progression to multiple myeloma. One area of current research is in new PET tracers. 11C methionine has had promising results for detecting bone marrow infiltration and in differentiating active disease from morphological scars more accurately. It is hoped that this imaging can be performed in earlier stages of the disease with increased sensitivity. Although not yet used in clinical settings, research into new PET tracers show promise for the future of PET-CT in plasma cell tumour imaging. In conclusion, both 18F-FDG PET-CT and MRI are suitable for the diagnosis of solitary plasmacytomas. However, due to the additional benefits of whole-body imaging for detecting spread and assessing disease post-treatment, the current literature recommends 18F-FDG PET-CT as the imaging modality of choice for the staging and diagnosis of solitary plasmacytomas and for creating the most appropriate treatment plan.